I think a lot of us, including myself, when we hear about working in pain management, we think it just would be awful dealing with patients who are in pain all day and having to deal with opioids and people drug seeking. Those are the things that come to my mind. But I'm going to talk to a PA today who has been working in pain management for 16 years, and she has a totally different view of the specialty. So stay tuned to hear what she thinks are the major misconceptions about pain management and what the good things are. Welcome, Karen, and thanks for joining us today.
Hi, Michelle. Thank you for having me.
Pain management. When I hear about this specialty, I kind of cringe inside. Was that
Mhm.
your initial thoughts about pain management, or did you have a more open, favorable opinion about it?
Well, honestly, I fell into pain management because I was desperately looking for a job. So I was not too picky about the specialty. At the time, I was looking for a job that had a better work-life balance. I wanted better hours, no weekends, no nights, no call. I really didn't think too much about what I was getting myself into, to be honest.
What was your career path from when you graduated to when you started pain management?
So after I graduated, I started working in primary care, and I had a hard time in primary care, primarily because the location of the job was far from where I lived.
Yeah.
I was driving about an hour in traffic, and it was really stressing me out. So I didn't last long in primary care, I have to admit. I didn't last long, and I quit.
Did you have a specialty in mind when you went to start PA school?
I did not. I was
Yeah.
pretty open-minded, and I thought honestly, I thought I would be happy in primary care. I was kind of surprised that I wasn't, but it just turned out to not be for me.
What is the typical patient population that you see on a daily basis?
I see mostly adult population, so anywhere from 18 years old to 118 years old, if you want to put it that way. The majority of patients have chronic pain, and chronic pain meaning they've had pain that's lasted more than 3 months. So, not a very long time, if you think of
Right.
the span of our lives. The patients have pain, whether it's neck pain, back pain, neuropathic pain, pain stemming from spinal stenosis, vertebral compression fractures, vertebrogenic pain, like post traumatic injury type
Mhm.
pain or post surgical pain sometimes. So, yeah, any type of pain is what we see here.
It seems like that every patient you must deal with all day long is going to be very frustrated and, upset, and it's going to be a very depressing day. Is that accurate?
There are some patients that come in a bad mood, but the majority, I would say, come in a fairly normal mood. But they're down. They're having a hard time. They're
Right.
having a hard time. If they were feeling fine, they wouldn't be in the office. I find that most of the patients are very thankful for what we do for them, and they know that we're really trying to help them, even if we don't get it right the first time. But as long as we have a treatment plan and they understand the treatment plan, they can be very patient with us as we go through the process.
I guess a lot of people, like myself, may picture a more kind of contentious relationship where the person's always kind of fighting you. But that's probably a bit of a misconception because you're saying most patients are pretty open to different treatment options and they're just a little bit more grateful and receptive because they want to do whatever to get out of this pain.
Yes,
Yeah.
and it is a misconception that, yeah, it hurts the specialty, I have to say. Personally, if I have a doctor's appointment and I tell them I'm a PA and they ask me, which specialty do you work in? And I said pain, the reaction is always, oh, that's the reaction. Like, are you happy there? So I was like, yes, I am. I'm happy. I'm fine. I'm fine. I've been doing this for a while. But it's a huge misconception. And I think what it comes down to is education. So part of what I do throughout the entire day really is educating the patients and letting them, like, and that's why I talked about the treatment plan earlier, is because if you explain to the patient exactly what we plan on doing, and you explain to them that this is not going to be like a light switch on and off. It's going to take some time. So just be patient. This is your diagnosis. This is what can happen. This is what's less likely going to happen. Once the patient understands all that, I find that it's just so much easier.
And I would assume that managing expectations are a big part of that education.
Yes, definitely. A lot of patients come in expecting to have zero pain. So part of the education is letting them know that the goal is to minimize the pain, not to take it away completely. We would love to take the pain away completely, but we can't guarantee that.
Talking about the diagnosis part, when you're working in pain management and somebody's been referred to you, I assume usually they come with some kind of diagnosis to explain that pain. But are you sometimes having to figure out the diagnosis exactly for yourself?
Yes, because a lot of patients come in with a diagnosis, for example, of sciatica, and they'll tell me, I have sciatica. And I'll say, great, where's your pain? And the reason is because sciatica essentially just means leg pain, but
Okay.
it doesn't tell me which dermatome is affected. Is it the L4? Is it L5? Is it S1? So what is it? So I have to obviously, go into, digging with the questions and interviewing the patient, trying to figure out what's going on. How are they exactly feeling their pain? And then getting imaging. And then that's when it's clearer to me, okay, this is what's happening with the patient.
And when it comes to the treatment plan, I think the other big red flag that goes up in people's mind when they think of especially pain management is I don't want to be writing opioids all day. I don't want people coming in drug seeking. I don't want to have these fights and I don't want to get people hooked on opioids. And I don't want my license to be in jeopardy.
We rarely start with opioids, and most of our patients are treated without opioids. Not saying that we don't use them at all. There are cases, especially patients who have cancer or patients who have compression fractures. Those patients will generally need a short course of opioids. It's rare that we have patients who are on opiates for years. Most patients nowadays recognize the dangers of narcotic medication, and I find that in the patient population that I treat, rarely do they come in demanding an opiate. It happens maybe once a month or once every couple months where I have a patient
Oh.
demanding Percocet prescription or Vicodin. It really doesn't happen that often. I would say over the years, I've noticed that the patients just are asking for these medications less and less. So most of the time, it's really not an issue.
So that's interesting to hear about the opioids and that people are demanding them less and less, and that it's not really a big issue in your practice. So, what are some of the other typical modalities that you use to treat people?
Other modalities include physical therapy, occupational therapy, chiropractic treatments. Some patients actually do really well with cognitive behavioral therapy. And then there's the injections, obviously, that we use. Medications also, so non-opioid medications like anti-inflammatory meds, SSRIs, SNRIs, those type of medications work really well also in controlling pain.
When you're going to send somebody for like some cognitive behavioral therapy, do you get a lot of people push back on that and say, "Are you telling me the pain's all in my head?"
We used to. I have to say lately, not that much. That's improved also. And I think it's because of the media with mental health and Simone Biles and Michael Phelps and Naomi Osaka, and they're talking about their mental health issues openly that now patients I've noticed are accepting that conversation a lot more easily than
Yeah.
they used to in the past, which has been great because the results are really life changing for some of these patients. Psychology is a huge part of our treatment plan. It's really important. Sometimes I will start them on medications like duloxetine or Celexa, for example. The medications can help with chronic pain, but if they're having a lot of mood symptoms, which is common in
Right.
patients with chronic pain, sometimes they'll come back and they'll tell me they feel great. Their pain is gone or almost gone, and they're back to enjoying life. So it's definitely been a lot easier the past few years.
And when you talked about the injections, what injections are you doing as a PA? And are there other injections that the physicians do that the PAs or NPs don't?
The PAs can do the trigger point injection, the joint injections, certain nerve blocks, like for median neuropathy, bursa injections we can do in the office. We also do ultrasound guided injections, which the patients love, by the way. As far as spine injections, like epidural injections, those the physician will do those. I do believe that in some states, some PAs are able to perform some fluoroscopic guided spine injections. But for me, I don't do those. The physician will do those. The physicians will also do spinal cord stimulation, peripheral nerve stimulation, nerve ablation, like the basic vertebral nerve ablation or facet nerve, rhizotomy.
And what is your autonomy like? Are you seeing new patients into the practice? Are you seeing them from the get-go and then you're the one that sees them all the time? Or does the physician have to see new patients first and then you do follow-ups?
I think it depends on the practice and on the relationship you have with your supervising physician. I typically see any patient. So I'll see the consults, I see the follow up patients. I'm fine with either. I'm comfortable with either. It's not a problem. I do like to rope in the supervising physician every once in a while because I think it's important for the patient to know all the members of the team.
Is this all strictly outpatient or are you ever doing anything in the hospital?
Yeah, my position is pretty much outpatient. In the past few years, I did go into the hospital to do some inpatient consults, but when I was hired, my particular position was to be in the clinic. That's what it was for. So that's where I spent the vast majority of my time.
But are there some APPs that work more often inpatient?
There are some, usually they're employees of the hospital.
They're just managing pain of any of the patients in the hospital?
Pretty much. That's pretty
Mhm,
much what it is. And sometimes they will help out with patients post-op for post-op
mhm.
pain. So I've heard of that also.
You said that part of the reason that you took this job was the hours and the work-life balance. So what is a typical outpatient pain management schedule, and do you have call or any expectations to work on weekends, anything like that?
It's, Monday through Friday, 9 to 5, 8 to 4, depending on where you are. No nights, no weekends, no call. Some positions here and there have call. My position has call. And it was only because the need came up past few years, but I haven't done call in many, many years. And the call is very light. It's telephone call. There are weeks nobody even calls me on my cell phone. For the vast majority of pain medicine, pain management PAs, yeah, there's no call.
You kind of touched on this a little bit, but what kind of personalities for providers do you think do well in this specialty?
I think you have to be a very good listener, number one, because patients in pain are dealing with a very physical and emotional situation that's extremely difficult. And if they feel that you're not hearing them, it really doesn't matter what you say. You can come up with the best treatment plan and they're out the door. They're not coming back because they felt that you didn't listen to them. And with that, you have to be patient because sometimes patients with pain cry or they're angry or they just kind of go on and on and on. So you really have to be patient and just try to work through that. If you are the type of person who's a fixer, you like to fix things, this is probably the specialty for you because, again, the goal is to minimize the pain, not to make it go away completely. So if you want it to go away completely, you probably have to go maybe in a surgical specialty or something like that. You also have to be someone who likes to think and analyze because pain management is not so black and white. You can have two patients with an L4-5 disc herniation, but their symptoms are totally different. The treatment plan will be different. The way to affect their life will be different. So you really have to be able to look at the patient that's in front of you and just come up with a plan that's good for them. So that requires a lot of thinking. And you have to also be a good communicator. And again, it's because the patients are going through so much emotionally, you have to be able to reach them, to help them understand what's going on. And that takes time. But at the end, again, the patients appreciate it a lot. I find I'm always so happy at the end of the visit when when a patient says, thank you for listening to me. Thank you.
Yeah.
Now I understand what's wrong with me. Now I know what I need to do. So when you hear that, it always makes you feel
Yeah.
good.
Yeah, and I do think that's a big part of it. I mean, we, are so rushed, like think of the primary care, so rushed for time and you listen to them to an extent, but you don't have time for them to like really lay it all out. And you have so many other things you have to talk about. And you may give them a diagnosis, but may not have the time or the in-depth knowledge to really explain what's going on with them. So that's probably a big thing when they get to you to have somebody who can listen and they feel like really understands what they're saying, but then also can explain to them what is happening and why they're having this pain. Because I think that when people have pain and they can't understand really why, I think that's harder.
No, you're absolutely right. Because at the end of the day, I find that you run into less problems with the patient when you do take the time to just explain to them what's going on.
And so when we talk about time with patients, because all this education takes time, and that is probably the biggest thing that everybody in all aspects of medicine is fighting nowadays. What is a typical schedule for you? Like, how many patients are you expected to see during a day?
I usually start at 8 in the morning. My last patient is booked around 4:10ish. I max out around 20, 21 patients. I don't want to go over that. And even then, I find that it's still a little much. I wish it was less than that. But there's not too much pressure on me as far as seeing more patients.
What are some of the things that have been the biggest surprise and have been more enjoyable in pain management than you thought they would be?
I really enjoy having a relationship with the patients. I think that's what gets me through the day, to be honest. Because we are dealing again with patients who are going through a lot emotionally and physically, you do have the opportunity to get to know them. You know them, you get to know their families. And I really like that. I really enjoy it. And by getting to know them better, it actually helps me
Mm,
treat them better,
yeah.
medically. Other things that come up sometimes in pain management are surprising diagnoses. There are times where patients will come in with lower back pain, for example, and during the physical exam, you realize they have these really hyperactive reflexes. What's going on? How has your balance been? Are you falling down? Like, what's happening? And oh, yeah, I'm having this and that, but my back is killing me. Okay, well, I'm going to get an MRI of your neck also. And they always look at me weirdly, but then you get the MRI of the neck and you realize there's a spinal cord compression, cervical myelopathy, and they have to go straight to surgery. So now I have to send them to the neurosurgeon, and that happens every once in a while, and it's always like, I'm so happy I saw that and didn't just say, all right, let's do an injection for your sciatica, and
Yeah.
when really they have something going on in their neck that's very important and needs to be treated right away. So once in a while that'll come up. What I've also learned are that some patients will also come in with a lot of pain and have these perfect looking MRIs. So that's the other thing too that, that I learned working in pain management, that you can still have pain, but your MRI looks great.
I think we've probably talked about all of the negatives or the challenges that people might find in this specialty, but are there any others that you wanted to highlight or that people should be aware of if they're going to go into pain management?
Actually, yes, there is one I didn't
Okay.
talk about. Because the perception of pain management is either we prescribe medications or all we do is injections, because that's the other one. That all they do is injections. They're just going to give you injections. Sometimes patients come in demanding injections. Sometimes it's not appropriate to do an injection for a myriad of reasons. So that happens every once in a while, and that can sometimes be a difficult visit. And again, it all boils down to patient education.
Did you have a pain management rotation in school?
No, I did not.
So if somebody is in PA school or about to start PA school and they have an idea they might want to work in pain management, besides a specific rotation in pain management, what other specialties would be helpful for them to have?
So I would say neurology, orthopedic surgery, psychiatry, and primary care. A lot of patients present to their primary care physicians first.
For people who may, already be working as a PA and looking at pain management, do you have any kind of resources or societies or anything that you would point them to?
Yeah, there's a lot. So there's the American Academy of Pain Medicine. There's also the North American Neuromodulation Society. The AAPA and the AANP also have a lot of resources, CME courses in pain management. If you're very serious about pursuing a career in pain management and you wanted to get some specialized training like certification, you could do that also. The American Pain Association provides courses for that. So there's definitely resources.
So is this a specialty that you would recommend would be okay for new grads to come into?
Because I started in pain management as essentially a new grad, I was less than a year out from graduation. I would say yes, it's new grad
Yeah.
friendly. I think most pain specialists who hire PAs and NPs are open to training.
So overall, despite the challenges that we have talked about, what would be your kind of parting thoughts that you'd want to tell people to encourage them to look at pain management?
I would say for PAs and NPs to just keep an open mind. There's a need for more pain management specialists. There's a lot of people out there who are suffering. They need our help, they need our guidance. So again, just be open to it, learn more about it, and I'm sure a lot of people will enjoy it more than they realize. Like I did. I didn't realize when I started in pain management that 16 years later I will still be in pain management,
Yeah.
and I haven't regretted any of the 16 years. I'm really happy in this.
I know dealing with the pain patients that I've had in primary care, I wasn't equipped to deal with them. So it made those appointments challenging. But when you're working in pain management, when you really understand the different causes of pain and you have different treatment modalities and you have resources, that probably takes away a lot of that angst and anxiety that we feel facing a pain patient.
Yeah, you're absolutely right. And it does take time. What I know now about pain management and the way I conduct a visit is certainly different than when I did back when I first started. I understand the patient population better now. So it's easier for me to figure out a way to reach them and help them. But it does take time. So I would admit to that at the beginning it might be a little bit challenging, but it's really rewarding.
So thank you, Karen, for telling us all about this specialty. I appreciate your time and thank you again.
Thank you so much, Michelle. This was fun.
Great. I'm glad you enjoyed it. Tell me down below in the comment section what you think about this specialty. Tell me if working in pain management is something you would ever consider or if it is an absolute no for you. Please subscribe if you like this content, hit the thumbs up if you've liked this video, and leave a comment for me down in the comment section. If you're interested in learning about what it's like working in other specialties, watch some of these videos here at the end or go check out my main channel page.